It. Okay, you can hear me now. And thank you for those who stuck around for the afternoon session. I appreciate that. You can tell everyone tomorrow how much they missed by not sticking around. So I do want to, I think it is connected, but it's a slightly more specific topic than we've been talking about throughout the day, but looking specifically at prescription drug abuse, mostly focusing in on the US, and it is certainly an area in the US that we've been struggling with for a number of years, and other countries more recently have been dealing with this as an emerging problem. Today I'll cover briefly the epidemiology. I think it's really fundamental to understand what's the problem and what's driving the problem before you start implementing policy, which has sort of been much of the theme of today. Talk about some recent connections between infectious disease and prescription drug abuse, primarily prescription opioids. And you heard about this earlier as far as burden of disease goes and how that connects in for hepatitis C and HIV. Talk about what we've been doing at the federal level within the US, and then highlight some areas of success. So looking at the epidemiology of prescription drug abuse, we have an annual survey, the National Survey on Drug Use and Health, which is conducted by my colleagues at the Substance Abuse and Mental Health Services Administration, and they asked questions about 4 categories of prescription drugs or psychotherapeutics. So prescription pain relievers or prescription opioids, sedatives, tranquilizers, and stimulants. And by far, across non-medical use, initiation, and abuse or dependence, prescription opioids have the largest numbers. And this just looks at 2014 data. You can see this is numbers in thousands. So slightly less than 1.5 million people reported initiation of non-medical use of prescription opioids. So that is in the past year, they've used prescription opioids for a non-medical reason for the first time. They may have used other substances previously, but this is their first initiation into non-medical use. And you can see for tranquilizers, stimulants, and sedatives, for the blue bars, there are fewer people who report that. For dependence or abuse, and the NISDA survey still uses DSM-4 criteria when they're asking questions, but essentially translate to the spectrum of opioid use disorders under DSM-5. Slightly less than 2 million people reporting dependence or abuse. And then when we look at past month non-medical use or current non-medical use, a little bit more than 4.25 million. And again, you can see that the numbers for tranquilizers, stimulants, and sedatives are less than prescription opioids. And primarily from this, as well as this next slide, which looks at drug-related mortality, much of the policy and programmatic efforts on prescription drug abuse have focused on opioids. They simply account for the largest fraction of morbidity and mortality. And when you look at people who are using prescription opioids, they're often using other prescription drugs as well, specifically benzodiazepines is a common occurrence. So when we look at the mortality data, this is just trends in the US from 1999 to 2013. 16,235 deaths related to prescription opioids in 2013. That's 4-fold higher than what we saw in 1999. You can see here for benzodiazepines, it's actually the second most common prescription drug involved in overdose deaths, but still significantly less than prescription opioids. And by themselves, benzodiazepines are very rarely the sole drug involved in an overdose death. About 5% of deaths involve no other drugs. And then psychostimulants have fewer deaths than both prescription opioids and benzodiazepines. And some of the psychostimulant deaths, based on the way we classify deaths in the US, could include illicit stimulants as well. So it's not just prescription stimulants. So looking more specifically at prescription opioids, as I said, much of our policy efforts have focused on that. We have, I think, only maybe one piece of good news in the US is that our initiation numbers have been declining for a number of years. And you can see here, compared to earlier in 2002, 2003, in 2014, we have significantly fewer people reporting initiation of non-medical use of prescription opioids. However, when you compare that to people who meet criteria for prescription opioid use disorder, as well as people who are reporting very frequent non-medical use, and that's a very high-risk group. Did I do that?
No, I don't think
You definitely don't want to look at that. So I'll continue on while that gets worked out. So when we look at really the problematic, the high-risk group for morbidity and mortality, we see trends going in the opposite direction. And particularly frequent use or more intense use and prescription, and the percent of people who report non-medical use that meet criteria for abuse or dependence has also been increasing in recent years. Any luck? Such a tragedy to be dependent on slides. All right. So to condense a pretty large number of studies into really what are the fundamentals of the characteristics of people who are abusing or dying from prescription opioids. And when we look at the demographics, as you saw earlier, males have higher rates of overdose deaths as well as abuse of prescription opioids. When we look at the mortality data in the US, 35 to 54-year-olds actually have the highest rates of prescription opioid-related overdose deaths. When we look at abuse, it tends to skew a little bit younger, 18 to 35. Non-Hispanic white populations and American Indians, Alaska Natives have by far the highest rates for prescription opioids. In our sort of socioeconomic and geography, uninsured populations or Medicaid, which is our public assistance program, sort of a federal state public assistance program, have higher rates of both abuse and overdose deaths. And then people residing in rural areas tend to have higher rates of abuse and death. From a clinical perspective, and I think this is really important in an area that's somewhat unique to prescription drug abuse, whereas some of the other illicit drug abuse we've been talking about earlier, that at least certainly in the US, this is a healthcare-driven problem, that as prescription opioid sales and distribution and prescribing of these drugs has increased, so has morbidity and mortality. And it's certainly the vast majority of people who are reporting non-medical use report the original source of the prescription opioid as a prescription, whether they be getting that from a friend or family member who got it from a prescription, or they got it from a prescription for themselves. And so understanding the clinical characteristics is important, both from a prevention standpoint, but also from a harm reduction or risk reduction standpoint about what behaviors and policy or program do we want to change in order to reduce risk. So looking at clinical characteristics, obviously chronic pain is a risk factor for overdose and abuse. That makes sense because that's a source of supply. A history of substance abuse, it doesn't have to be specific to prescription opioids, really any substance abuse history is a risk factor. Having a mental health condition is a risk factor. Of course, reporting non-medical use, so using these drugs outside of their accepted medical indications. Receiving multiple prescriptions from multiple prescribers or multiple pharmacies is significantly associated with an increased risk in both abuse and overdose. High daily dosages, which is something that from a policy perspective, there's been a lot of focus on at the state level and now more so at the federal level, that as you increase the dose, the odds of dying from an overdose greatly increase. There's not a lot of evidence to say that as you increase the dose, you get better pain relief. So that's a potential policy area that has the potential to reduce risk without having a negative impact on pain, which is important. And then the combination of opioid analgesics and benzodiazepines, again, is a significant risk factor. And when you look at mortality from 2006 on, all of the increase for prescription opioids has happened when prescription opioids and benzodiazepines were co-used. When we look at the people who died, it's really being driven by the combined use. So we can't talk about prescription opioids in the US without talking about heroin and the interconnectedness and what we're currently dealing with. And we've really seen a demographic shift in heroin use in the US. So for many years, it was a non-white, urban problem, generally in the US. And we really have seen a shift to certainly more non-Hispanic whites, more rural areas. And the first source of an opioid is by far a prescription opioid, where historically the first source had been heroin. So we have seen a demographic shift, and we really see that people who are frequent past year non-medical users of prescription opioids are really the risk group for initiating heroin use. This is from a study I did a couple of years ago, that people who report using 100 days or more in the past year have significantly elevated odds for using heroin in the past year, for injecting heroin, injecting prescription opioids, meeting criteria for abuse or dependence on heroin or prescription opioids, and then saying that heroin is fairly or very easy to obtain compared to less frequent users. And when we look at, we've seen a pretty dramatic spike in heroin deaths, which really has gotten the attention of policymakers in the last 2 years. For a number of years, we really saw a pretty flat line. As we were seeing increases in prescription opioids, we were not really seeing increases in heroin. And really starting in 2010, and really there was a significant jump between 2012 and 2013, but more than 8,000 deaths. So more than a doubling in the number of deaths over a 3-year period. And we see that rise in deaths is tightly correlated with the increase in abuse and dependence on heroin. And it's really important from a policy perspective to think about focusing on the people who are initiating prescription drugs, who are abusing prescription opioids, and identifying them early has potential implications to help drive down the heroin problem. So getting them into treatment, into recovery, has a significant potential to impact the increases we're seeing in heroin. But it's also important in the context that people are not abusing prescription opioids by themselves. Similarly, people are not using heroin by itself, and that other substance use disorders or substance abuse and dependence are significant risk factors. By far, the most significant is abuse or dependence on prescription opioids. This is a study I did with CDC colleagues this summer, and even accounting for other substance use, demographic, geographic, other factors, we see that prescription opioid abuse or dependence is the strongest risk factor for heroin abuse or dependence. But cocaine, not surprisingly, is the second among the abuse or dependence criteria. But marijuana and alcohol were also significantly associated with heroin abuse or dependence. And when you look at, really, it's a polysubstance issue that people are abusing multiple substances, which I think has really important implications for both prevention as well as treatment. And understanding that they may be coming in for something that they think is their primary drug of abuse, but there are a lot of other issues that have to be dealt with in order to successfully have people move into recovery. So as I mentioned, in the US, as we've seen this increase in abuse of prescription opioids now transitioning to increases in heroin, we've seen a corresponding increase in injection drug use. This comes from an MMWR from colleagues at CDC in the hepatitis branch, where they looked at injection drug use being reported among people who are coming into publicly funded substance abuse treatment, or the TEDS data in the US. And you can see here that any opioid injection, which is the solid blue line, has been increasing really at a pretty significant clip since 2007. And other drug injection, while it's been increasing, certainly has not been to the same extent as we see for opioids. And along with that, we're seeing a reversing of trends around hepatitis. So for many years, we were seeing declines in hepatitis C rates in the US. Now we're seeing significant increases, and much of that is happening among people who are less than 30 years old, which is really the main cohort of people who are injecting drugs, especially the newer injectors who may have additional risks for hepatitis C because they're inexperienced injectors. But we can see here from CDC's data that really the vast majority of states were reporting increases in hepatitis C. There have been a number of other studies, smaller studies looking at cohorts of people who are injecting prescription opioids, or either in looking at outbreaks of hepatitis C, and really prescription opioids are the common element among many of those cases. So you can see here the magnitude may differ, but the direction is all the same as far as increased odds for hepatitis C for people who are reporting injection of prescription opioids. And the last study I just thought was an important point from treatment side was that the giving people medication-assisted treatment for opioid use disorders was a significant protective factor for hepatitis C compared to people who did not receive that treatment. And then most recently, there was an outbreak of HIV in Indiana, a small rural town in Indiana of about 4,000 people, and they had 180 or so HIV cases diagnosed in a very short period of time. They normally had 1 or 2 cases a year, so the rate, 180 cases over 4,000 people is probably one of the highest rates currently across the globe. What's interesting is that when you look at about 90% of these people were co-infected with hepatitis C, and when you look at the hepatitis C virus in that community, it was long-standing. The HIV cases, no doubt, were new cases, but there have been long-standing drug use and injection drug use specifically in that community. They estimate about 600 of the 4,000 people in that community are injection drug users. So it took one case of HIV being introduced into the drug injecting network to rapidly spread. And certainly more information will come out on this, but in talking to, I worked with folks at CDC who were investigating this, and in talking to the community, there was a lot of misinformation around safe injection practices. Certainly there was a ban on syringe access programs in Indiana, very little access to evidence-based substance abuse treatment, specifically really no access to medication-assisted treatment. So it was a perfect storm for something like this, where there was an unrecognized problem in the community, there was lots of stigma, there was misinformation, and the resources were not there to deal with it. And we estimate that there are a number of other counties in the US who have similar circumstances. And public health authorities have been working with those counties and with states to say, take an assessment of what's going on, because this is something that could happen to your community. It really wasn't on a lot of people's radar. It's sort of a theoretical possibility, but I think people were focusing on hepatitis C more because it's so strongly associated with injection drug use. There also have been cases of synthetic opioids coming in to various areas, primarily in the Northeast. And this is a slide from DEA, which looks at forensic laboratory testing for cases of fentanyl, and either fentanyl cut with heroin or fentanyl itself, which is leading to significant numbers of overdose deaths when clusters essentially within short periods of time. And Rhode Island had a particular outbreak in 2013. And then the last area, sort of from an epi perspective, is that we in the US do not have enough supply of medication-assisted treatment, particularly opioid agonist-based medication-assisted treatment. This is a study I did with CDC and SAMHSA colleagues this past year, where we wanted to compare abuse or dependence rates or opioid use disorder rates by state with maximum potential capacity for agonist-based treatment. And everything below the red line is an imbalance where there's more potential need for treatment compared to capacity to meet that treatment need. And even in the states that are above the line, this is at maximum capacity, and we know that people who are prescribing buprenorphine are not maximizing their potential to do that. We know that opioid treatment programs in the US are operating at near capacity or over capacity. So we have a significant issue on the treatment side, but which has important implications for the issue overall. So from the federal perspective, in 2011, the White House Office of National Drug Control Policy released essentially the federal government's blueprint for addressing prescription drug abuse, and it focused on 4 particular areas: education, monitoring, disposal, and enforcement. And within the education bucket, it was a focus both on patients and the public, but really a focus on providers. We know that providers in the US get very little training on substance abuse, as well as on pain management, and so it was looking at what initiatives could be put in place to shore up education for providers. Monitoring was looking at prescription drug monitoring programs, which are statewide databases that capture information on dispensed controlled substances. We don't have a uniform electronic health record across the US that could provide that information, and so these databases have been set up over the last 3 or 4 decades. More recently, in the last decade, most states have operationalized PDMPs. Disposal is another area that this particular plan focused on. And in the NISDA survey, the annual household survey, about 55% of people report receiving the prescription opioid they non-medically used from a friend or family for free, and about another 15% report receiving it from a friend or family, or buying it or stealing it from a friend or family. So 70% coming from friends or families in some shape or form. And so the policy around disposal was really important, just that it's available, it's accessible, people will use it. And then lastly, enforcement, which is to my Department of Justice colleagues and others at the state level who are looking at pill mills, so doctors who are prescribing outside of medical bounds, looking at drug diversion, those types of activities. From the Department of Health and Human Services perspective, this is an infographic that we developed when I was at CDC to really say what are the touch points for intervention. And again, this is somewhat different than traditional illicit drugs because you have this medical component, you have insurers who have a role to play, you have pharmacies who have a role to play, and you have manufacturers. And we have touch points both at federal, state, and local levels for all of these. And certainly focusing on the upstream issues is a cost-effective way, as we've talked about today, prevention. So thinking about what can be done from the FDA perspective on manufacturers, so development of non-opioid alternatives for pain or products that are less likely to be abused, abuse-deterrent formulations. When we look at prescribing in the US, it's pretty consistent across states that a very small fraction of the providers prescribe the majority of opioids. As a general rule, 10 to 20% of prescribers are prescribing 70 to 80% of the prescription opioids. And certainly there are cases, Florida was particularly well known for pill mills, where you go in, you pay your $300, you get 180 oxycodone, and you don't actually get a medical evaluation, you're just paying for drugs. Those exist in other states, but not necessarily to the extent. But that accounts for a large fraction. And then you've got really problem prescribers who are accounting for a large volume of drug and who are not providing quality care. And interventions for these two groups are quite different than interventions for doctors who are trying to do the right thing but are just not well informed on what to do. So there are a series of policies that have been put in place at both the federal and state level to try to address this. So they stem from, or the spectrum is from education. So some states are requiring education on pain management, all the way through removing someone's licensure and going after them as someone who's not practicing medicine, but is essentially distributing drugs. And then when we look at insurers, it's actually growing evidence base for things that insurers can do. And in the US, we have a very fragmented healthcare system with private and public insurers, and there's not a lot of information sharing. So having them incorporate their data that they have to identify both providers and prescribers, prescribers and patients who are at risk. So that for prescribers, insurers use their data to identify people who are prescribing large volumes of drugs that don't seem to be explained by the medical conditions of their patients, and they can take action against those providers. And similarly for patients who are seeing, again, as a high risk factor, multiple providers, multiple pharmacies to obtain controlled substances, there are interventions where they can only see one prescriber, or they inform other prescribers that the patient is receiving multiple prescriptions from multiple providers. So it gets a bit complex because our health system is pretty fragmented, but there is a growing evidence base for those types of interventions. And then lastly, there are particular people who are at high risk who need to be identified as high risk and addressed appropriately, whether that be slowly reducing their opioid dose and getting them off of other drugs that might increase their risk for overdose, or engaging them in the treatment system if there's a diagnosable opioid use disorder. And then you have patients in the public who need to be informed about the problem, who certainly don't need to be selling or sharing their medications, understanding how to store and dispose of them properly. So it's really a series of interventions that are very upstream prevention, as well as sort of, I use primary, secondary, tertiary, which is not what's been discussed here today, but along similar lines, thinking about secondary prevention where you have people who are at risk, what are we doing to reduce their risk? And then, from a tertiary perspective, you've got people who are already diagnosed or have overdosed, so what do we do for them? Things like naloxone, medication-assisted treatment, those types of things. I'm probably way over time, but I'll try to finish very quickly. So within HHS, our secretary released a strategy in March of this year, which really said, let's look at all the evidence. What are the interventions that we think will make the greatest impact, that we have evidence, at least some evidence, to support their use? And the three areas that we landed on are improving opioid prescribing. Fundamentally, there has to be a shift in prescribing. That's what's been the underlying driver of the problem. Expanding access to naloxone to reverse overdose, and then, of course, expanding access to medication-assisted treatment. So we're trying to hit it from both the upstream and the downstream. We do have a number of successes, and I will make my slides available to others. But from a federal level, we rescheduled hydrocodone combination products, which means that they're more restricted than they previously were. And it's really the first time we've seen a significant shift in prescribing. So you can see here the black line represents essentially October, the third quarter of 2014, where those products were rescheduled, and we see about a 22% drop in prescriptions for hydrocodone combination products, which are the most commonly prescribed drug in the US, among all drugs that are prescribed in the US, about 130 million prescriptions a year. When we don't see a compensatory increase in other prescription opioids. So now the big question is, did we actually see a reduction in abuse and overdose, which is what we want? We see a reduction in supply, so future research will look at that. And then you've already talked some about this, the Strengthening Families program. There's specific data related to non-medical use of prescription opioids stemming from those types of programs, which is very encouraging that we actually have specific RCTs that have looked at prescription drug abuse prevention. And then the last few slides are just different states who've implemented multi-pronged strategies who've started to see reductions. We see most states still continuing to have increases in overdose deaths and abuse. Washington State, Florida, Kentucky are the three states that I would say you can read on the slide specifically to learn about what they've done. They have articles supporting their evaluation. And then naloxone is another area where we're rapidly moving policy in the US, mostly at the state level, where states are passing laws to allow behind-the-counter or standing orders pharmacist-initiated naloxone to reverse overdose. And this is just an example from Rhode Island where you see a pretty clear connection in as naloxone increased, overdose deaths decreased. And then the last thing I'll say is that similar to what has been shared today, there's a lot of stuff happening, there's not a lot of evidence, and that applies very much to prescription drug abuse. We did a systematic review a couple of years ago, and we really see low to very low quality evidence for a variety of interventions. And so there is a need to fund research, fund rigorous evaluation of all of this, and try to do it as quickly as possible because people are putting things in place now, and we need to understand how they're impacting in both positive and unintended ways. And this is my contact information. Feel free to email me if you have any questions. Thank you very much.